A very good morning to one and all, and I'm glad that you have all joined us today for our national test and discussion chapter, or the test and discussion part of our subject ophthalmology at medpg and Medico. So here we are going to today discuss a few questions which are very crucial from the exam perspective. And along with these questions, I'm going to touch a bit in detail about the various subject aspects that are pertinent from the NEET PG perspective, right? So now, one important point before we go ahead is today's topic is broadly divided into two categories. One is a set of questions which are predominantly clinical based, and those questions are going to aim at trying to make you understand about the various clinical aspects, how they can be asked in the competitive exams, both NEET PG and INI-CET, and how to approach them, and a little bit in detail about the subject or the topics that are related to it. The second set is going to be image-based questions, where it is going to work more like OSCE and spotters, because that is the kind of new pattern where the students are expected to know in detail about the spotting aspects or the image-based questions that can be asked per se as an image itself, with a very minimal detailed question in the NEET PG or INI-CET exams, right? So these are the two broad groups of questions that we are going to discuss today. And one more important point is, today we are also going to see how to sort of rule out the other options and try to arrive at a particular option as a strategy to solve these questions, okay? So without further ado, let us move on to the first question for today. Right. So here, a patient with anisakenia experiences significant visual discomfort and image size disparity between two eyes. What is the most likely cause of anisakenia? So here, what is important is for us to first understand what is this anisakenia. So in ophthalmology, the first and the most important factor is to understand the various terminologies, because it has its own set of terminologies just like any other specialty, right? And the first point is understanding the basic aspects of the terminologies and nomenclature. So first point, unequal refractive errors, B, difference in corneal curvature, C, difference in lens thickness, and D, variations in retinal image size. So here, one important point is anisakenia is actually caused by difference in retinal image size between the two eyes. Okay, very important point is it is a retinal phenomenon. Okay, so a retinal phenomenon is very crucial to understand and differentiate from other aspects like refractive error. So it is the problem in the perception of the image that counts here. So the condition results from unequal refractive errors or significant difference in the optical properties of lenses in each eye. It leads to visual discomfort and difficulties with depth perception due to the disparity in the perception of the image sizes. So that is the most important point I want to drive here, is that the pathology may be in refraction, may be in lens thickness, okay, and can also be in cornea, okay, but ultimately it is the perception of the image that is different between the two eyes that creates this confusion. Now, this anisakenia can be broadly divided into two ways of classification. The first is static anisakenia, where the image size is different in each eye. So here you can see, this is the image that I have included, is that when the patient is experiencing an inequality in the image size between the right and the left eye without involving any motion, there is no movement of the eyes, okay, then it is called as static anisakenia. Whereas Dynamic anisogenia is when the glasses are making the eye move, okay, move, and the image being perceived, okay, inequally when the eyes are moving at a different rate. Okay, so dynamic means there is some motion that is involved, and that results in the dynamic anisogenia. Okay. So these are the various types of anisogenia that you should be aware of. Okay. So first, this is the normal image. Okay. So whenever there is spherical anisogenia, it appears altered in size. Okay. Second, when it is cylindrical anisogenia, that is cylindrical difference in the power between the two eyes, what happens is there is elongation in a particular axis. Okay, this is one axis and this is the other axis, right? So if it is in one of the meridians or the axis, if there is elongation or stretching, then that is cylindrical anisogenia. Now comes to prismatic. Prismatic means involving prisms. So what happens in prisms? See, prism is an optical device which deviates the path of light. Okay, so whenever a ray enters towards one side of the prism, okay, this is always bent. Okay, so let me put it in a better diagram format. We've all read this in optics. Okay, so can you see this is how actually the light is supposed to go, but the light ray is deflected here, right? So what happens? Always remember that the object is perceived towards the apex. See, this is the patient, sorry, this is the object and this is the patient's eye. So when the patient is seeing through the prism, what happens is the object appears as if it is being deflected to a different. This is exactly what happens if you have played this game where the pond is filled with water, okay, and there is a cup in the bottom, right? So what happens when somebody throws a coin, you're trying to aim it here, but actually the coin falls outside the thing because there is a deviation in the amount of rays that enter your eye. So for example, this is perpendicular, and if it goes like this, it's supposed to go like this, but it will refract less and go slightly deviated. So these are all prismatic effects. Now why am I mentioning that here is because this prismatic effect acts in an axis, okay, in a particular direction. So here it is very less stretched and here it is more stretched, correct? So there is a specific group of prisms called as Fresnel. Actually spelling wise it's Fresnel, but it's actually Fresnel prisms, okay? Fresnel prisms. Where do we use these Fresnel prisms and how do we use this? I'll tell you. If there is a spectacle, right, like this, okay, if there's a spectacle and if the patient is having squint, okay, then a prism is attached to one of the glasses and this is like a sheet of paper. It is not like a proper solid prism that we use while we check for squint, okay. So this is like a sheet of paper which has many small prisms, okay, eventually adding up to an effective big prism like this. So what happens is if the patient is having a squint and experiencing diplopia, which is double vision, by using this paper we can avoid or reduce the diplopia, okay, by using these Fresnel prisms till the time the nerve recuperates, recovers, and then the squint is corrected. Especially in cases of traumatic third nerve palsy, etc., the squint will take some time for the neurological recovery, right? During that period, if the patient, or even the sixth nerve palsy, okay, where the deviation will be inside towards the nose because the lateral rectus is gone, right? So in such cases, what happens is you use Fresnel prisms to temporarily counter the diplopia and thereby helps in avoiding this diplopia and imbalance while the patient is doing his routine activities, right? So when we use that prism, the image is distorted like this. So in one eye, it will be like this, and in the other eye, the image may be normal because the patient is not having this Fresnel prism. Because you attach a Fresnel prism only to the eye where you want to correct the deviation, right? So that results in prismatic anisokinia. Okay. So now these are three different types of anisokinia which are associated with difference in spherical power and cylindrical power and prismatic power. Now we are going to look at specific types of anisokinia which are associated with high power lenses. Okay, so what do I mean by high power lenses? Okay, so look carefully. So here what you're seeing here 1 and 2. Okay, so this is called as pin cushion. Can you see here? And this is called as barrel distortion. Okay, so what do I mean by this? In high plus lenses and high minus lenses. Okay, where do you give high plus lenses? One very important indication which was there before but is coming down in these days is aphakia. So in aphakia, the method of correction, at least in earlier days, was aphakic glasses. What about these aphakic glasses? They are nothing but high powered, okay, high powered biconvex lenses. Okay, so what were the problem with these aphakic glasses? They were high powered, because of which two things used to happen. Number one, very high magnification. So we've seen in earlier discussions, right, and even in the question answer sessions in Medico app, is that whenever there is increased magnification, automatically the field of vision decreases. Is it clear? So whenever there is an increase in magnification, this applies to one more very important phenomenon in our ophthalmic practice. Can you imagine or can you think about it, which I have discussed before in previous classes? Yes, it is actually the difference between direct and indirect ophthalmoscopy. One of the very important points is direct ophthalmoscopy. It gives a very high magnification of almost 15 times the actual size. But what is the loss in that? You will be able to see only the disc and maybe only the macula at a single point of time, and you have to move to be able to see between the two. And it is not possible to see the retinal peripheries using a direct ophthalmoscope, because periphery means you need to have a better field, and that is offered by indirect ophthalmoscope where the magnification is only 2.5 to 3 times. But at the same time, you are able to see the peripheries to look for any problems in conditions like high myopia, like lattice degeneration, etc. Okay, same way here again, aphakic glasses have very high plus power, because of which the magnification is very high and the field of vision is low. Okay, now what happens is, this image, when the field of vision is low, it appears to be, and one more point is that the rays which pass through the center, right, so they have a least amount of deviation, but when the rays in the periphery enter, they are going to get deviated the maximum, and maximum so with high powered lenses. Correct? When the power increases, the amount of this convergence is going to increase. So what happens is, these peripheral rays, they get cut off. Okay, so when they get cut off, you are actually going to see a decreased entry of peripheral vision, that is basically decrease in the field. So what happens is, the central image appears to expand and try to fill the remaining, because there is peripheral absence of image perception, right? So see these, it appears as if the central squares are normal, but the peripheral squares are trying to further stretch peripherally and go and cover the whatever remaining area of the field of vision, which is not being perceived by the peripheral rays being scattered away or not converging properly, right? I told you. So those are called as spherical aberrations. Remember, spherical aberrations increase with the increase in power. Okay. Now look at this. This is called as barrel distortion. Barrel, you know, right? In many cartoons also we see that barrel is where we store huge amounts of alcohol for fermentation. That's why it's called as barrel. Okay. So this barrel is exact opposite when you see with high minus powered lenses. Okay. So what happens is in patients with high myopia, okay, high myopia, when you want to correct it using high minus concave biconcave lenses, so what happens here? Here the rays get diverged away, right? So when that happens, the exact reverse happens. The spherical aberrations still persist, but the corners tend to come in and try to try to reduce itself to the central portion, and thereby facilitating, or not facilitating, making it appear as if it is barrel distortion. Looks like a barrel. Okay. So this is called as barrel distortion. And oblique distortion is when there is a difference in the axis. Okay, and that is not corrected properly, okay, between the two eyes. What happens is it should be like this. Okay, the dotted is the right way of it and it appears oblique. Okay, so in one eye the axis is proper, the other eye the axis is abnormal, then it appears to be tilted, right? So these are the various types of anisocenia that you must be aware of. And one second, let me just get this erased. One important point that I want you to know is this anisocenia must be separated and differently understood from another topic, that is anisometropia. So remember, anisometropia can result in anisocenia, but here it is very much got to do with refraction. Okay, when there is an optical state with equal refraction in the two eyes, it is called as isometropia. When the total refraction of the two eyes is unequal, it is called as anisometropia. So remember, when the power is different between the two eyes, which is the most common case, almost everybody is anisometropic to a certain extent. Okay. Now remember the difference in the perception of anisocenia. Okay. Okay. Up to 5 degrees, 5% is well tolerated. So any difference of this sort, okay, if it is up to 5%, it is very well tolerated by our brain in being able to perceive and adjust and adapt. But if it exceeds this 5%, that is when this problem is. So here, that is the cutoff for anisocenia. Okay, note this point. A difference in one diopter in the two eyes causes a 2% difference in the size. So this is what I was telling you. 5% difference in the retinal image of the two eyes is well tolerated. So can you tell me, if you ask me, what is the power that is the difference that can result in a significant visually perceivable anisocenia? See this, if it exceeds around 2.5 to 3 diopters, okay, it crosses the 5% mark, and hence this amount of difference in the refractive error between the two eyes is a significant cause of concern. Okay, right. So what is the most important point I want to drive home from this question is anisocenia. What are the different types of anisocenia? What is anisometropia? Okay, and the amount of tolerable anisocenia that can be easily accepted by the brain as the difference between the size of the, or the perception of the two images between the two eyes. Okay. And one important question which was asked in the previous years is, remember this pin cushion, okay, and barrel distortion. Okay, this is not because of cylindrical lenses, but because of high powered spherical lenses. Is that clear? So this was a supposedly trick question, I guess, that was asked in the previous years, but it is because of the high sphere power and not cylinder power that is the cause of this problem. So I hope it is clear. So we also touched a little bit upon FAK correction also, and that needs high powered plus lenses, right? So that is about the first question. Okay, now let us move on to the second question. A 65-year-old patient is being prepared for a routine eye examination with pupillary dilatation. Which mydriatic drug should be used cautiously due to its potential to increase the blood pressure? See, many times the question may not be as clear and straightforward like this. Sometimes they can just stop saying should not be used and stop it here. Okay? This part they might expect us to know by ourselves, okay, or they can even say only this part and say which mydriatic drug should not be used. So for this we need to understand what are the options and try to group them into families. Tropicamide, cyclopentolate and homotropin, all of them are muscarinic antagonists. What is nicotinic and muscarinic? They are parasympathetic receptors. Okay, so only difference first of all is phenylephrine, which is an adrenergic agonist. So what am I trying to do by saying this? I was telling you in the start of the class, right? Not every time are you expected to know everything about the question and its details. Sometimes you can use a simple strategy of trying to group the different options that are given to you and try to find the odd one out. And to be able to group that, you need to have some basic understanding of pharmacology. So here, this is the concept of vertical integration, right? So where there is a connection between some of the basic sciences and the second year subjects and clinical subjects. So this is one such topic, right? So always remember the topics which have this sort of a vertical integration are more likely to be asked because they expect you to be very strong in the foundational subjects, and being able to apply that in clinical sciences really adds to the value, right? So see this, by default we know phenylephrine is the odd one out and hence the answer, but why here? Why is it that phenylephrine is to be avoided in patients with hypertension? Let's discuss. So phenylephrine is actually an alpha adrenergic agonist. Okay, so it is a sympathomimetic, right? So it leads to systemic vasoconstriction and increased blood pressure, especially in patients with pre-existing cardiovascular or hypertension. So the question might be like this in your minds. After all, we are putting a drop or maybe 2 drops in the eye. How is it going to go and raise the systemic BP? To answer that question, we need to understand a very important concept of tear drainage, right? So this is the eye, right? So this is the eye, and from here we have this drainage system. I'll also touch upon this topic here, okay, so that it gives you a little bit of extra information also, correct? So this is a tear drainage system. So this is the upper canaliculus, lower canaliculus. Some people have a common canaliculus, okay, that drains into the lacrimal sac. Then this is the nasolacrimal duct, correct? So this is the basic anatomy of tear film drainage. So what is the condition which causes the inflammation of this? Okay, which is called as the inflammation of this sac. It is called as acute dacryocystitis. Okay, and in children by default there is a valve here. Okay, all of us have, but in the children sometimes this valve may be underdeveloped, and that's called as valve of Hasner, right? So this may be blocked and that results in tearing, usually unilateral but can be bilateral, in newborns and children and infants. Okay, and that is called as congenital nasolacrimal duct obstruction. And what is the initial treatment? It's called as Krigler massage. Okay, so what is Krigler massage? You apply pressure starting from the medial canthus along the nasal aspect, okay, all the way down with adequate pressure. It is just like squeezing the toothpaste, pack. So when the toothpaste is almost about over, you nicely squeeze it to take out the remaining of it, right? So exactly the same thing, you're going to press this nasolacrimal duct against the nasal bone and try to squeeze out the tears that are stuck there, thereby preventing the blockage and allowing for flow. Okay, so just to touch upon this topic also, because this can be, Krigler's massage, etc., can be a potential question. Now, why am I talking about all this drainage here? Is because where is it draining to? Okay, now we've learned in anatomy that the nasal cavity is divided into superior, middle, and inferior meatus. So this valve of Hasner is opening into the inferior meatus. And remember, students, the nasal mucosa, right? The nasal mucosa is highly vascular. Okay, it has such rich blood supply. And remember, many mucosae in the body are quite absorbent in nature, right? So they have this ciliated epithelium in the anterior part and respiratory epithelium in the posterior part, right? So they have a tendency to increasingly absorb the contents that is, that they are subjected to. So by doing that, what it does is it ends up absorbing the drops, okay, that is applied to the eyes, which gets drained through this nasolacrimal duct into the inferior meatus. That is how the drops phenylephrine that is applied to the eyes or the conjunctival sac is eventually absorbed into the systemic circulation, and that is adequate enough to raise the blood pressure momentarily or temporarily. And that in a previously hypertensive patient, already the patient, when they enter the hospital, they are quite anxious, and that itself results in a higher blood pressure. When you dilate them, they're thinking that they're being subjected to some serious procedure, and that further worsens it, and this phenylephrine adds to all these problems and temporarily, momentarily shoot up the blood pressure, and that can be deleterious to the patient. Okay, so one more important point, there is, because it is only an adrenergic agonist, one thing is important to know is that it is a pure mydriatic. So in patients, okay, whom you don't want cycloplegia, okay, ideal is to go for phenylephrine. What do you mean you don't want cycloplegia? I'll explain. See, what is mydriasis? What is cycloplegia? The problem is both of them happen almost always simultaneously, that we fail to differentiate between the two individual processes that are happening simultaneously in our eyes. So first is mydriasis. Mydriasis simply means the opposite of miosis, which is dilatation of pupil. That's all. There is nothing more to it as far as mydriasis is concerned, right? Whereas cycloplegia, remember students, cyclo is a term that is often used to refer to the which part of the eye which part of the eye? Ciliary body. Okay, so ciliary body, anything to do with pathology, or you're messing around with the ciliary body in the terms of dilatation, paralyzing it, etc. Okay, it is all referred using the term cyclo. Like I mentioned, right, the nomenclature in ophthalmology is the first point you need to understand to be able to answer even other questions that have these terminologies, right? So cycloplegia is when you're trying to paralyze the muscle in this body, which is the ciliaris. What does the ciliaris do? It makes the zonules tense or lax. So in this process is what is referred to as cycloplegia. We learn in neurology, right? Hemiplegia, right? So you're going to basically paralyze the cyclo, that is ciliary body muscle, which is ciliaris. So they are actually two independent processes, but because there are receptors that are common between these muscles, right? Which muscles? So this I told you is ciliaris, right? So constriction of the pupil is brought about by sphincter pupillae, and sphincter pupillae is supplied by adrenergic nerve, whereas dilation of pupil is brought about by parasympathetic supply, and that is by dilator pupillae. So these are the three intraocular muscles. We speak about extraocular muscles, right? Recti, obliques, levator palpebrae, right? So these are the intraocular muscles, but they are autonomic in supply, meaning they are controlled by the sympathetic and parasympathetic nerve supply, right? So the ciliaris is what is cyclopleged when we are going to give parasympatholytics like tropicamide, okay, and then homatropin, and then cyclopentolate. Whereas this also acts on this dilator pupillae and causes the dilatation of pupil. So because they both share the muscarinic receptors, which both ciliaris and the dilator pupillae, sorry, the sphincter pupillae. Restriction is by sphincter pupillae. My mistake. I'll just go over this again. Sorry for the confusion. I'll just repeat this. So sphincter pupillae is supplied by parasympathetic. So, and that is what is blocked by tropicamide. That results in what? Mydriasis. Okay. Whereas dilator pupillae is by adrenergic or sympathetic, and that is what is blocked by or activated by phenylephrine. Sorry for the real confusion, students. So this is what happens. So I was saying that this muscarinic receptors are there in both sphincter pupillae and in ciliaris, right? So the sphincter pupillae, once it gets blocked by a parasympatholytic or a parasympathetic antagonist like tropicamide, it loses its function. Dilator pupillae takes over, and that results in dilatation of the pupil, which is mydriasis. Okay. Whereas the sphincter pupillae is going to bring about constriction, right? When you activate the dilator pupillae by using phenylephrine, it only acts on the dilator pupillae only. There is no receptor on the sphincter pupillae or the ciliaris. So thereby you can produce only mydriasis using phenylephrine. So in patients whom you want to dilate the pupil just to be able to see the fundus and do not want to unnecessarily cycloplege the patient, which leaves them difficult to work for at least the next 3 hours, then you use phenylephrine. So let us now understand the various properties of this cycloplegics and mydriatics. So first and foremost, the strongest of them all in the family is atropine sulfate. Okay, atropine sulfate is indicated in children less than 5 years. Now, what do I mean by this, or why am I saying this? See, atropine, if used as drops, okay, can enter the same nasolacrimal duct that we discussed and can go to the nasal mucosa and enter the systemic circulation. Am I right? So in children, what happens? We've learned, right? Red as beet, mad as hatter. Okay, all these aspects we've learned in forensic medicine. Poisoning with atropine. Okay, atropa belladonna. right? So what happens is these systemic manifestations happen when you use it in the drops form. Okay, to avoid that and make this formulation stay in the eye and also act better. Why act better? Because you want to increase duration of action in the conjunctival sac. Okay, you wanted to stay in this conjunctival sac because you wanted increased duration of action, because the cyclo aspect or cyclo strength, okay, of children is very high. Okay, they can have excessive accommodative spasm. Okay, the muscles in the ciliaris or the ciliaris muscle is very highly strong and having an extremely good tone in children, which allows them to accommodate excessively. So those are the patients who have a problem of accommodative spasm. So why are we so bothered about all this? Okay, why do we have to cycloplease the patient, and then recheck the power, etc. So I'll tell you of a very interesting reason why we do this. Okay. So there is a condition called as pseudomyopia. Remember students, this is the most important culprit that we want to identify, and that is why we do cyclorefraction. Okay, so see this, whenever there is contraction of the ciliaris muscle, accommodation happens. I hope you are aware of what the process of accommodation is. For those who don't have a clarity, I'll explain again. So ciliaris muscle is like this. Okay, this is, I'll draw it here. So ciliaris muscle is like this. So this is the ciliary body from which there are zonules. So these are the zonules which are going to hold the lens capsule in position, right? So what happens when the ciliaris is going to contract? It is going to make these zonules lax, okay, and it increases the convexity. Okay, from this the lens becomes more convex. What does this do? This increases the effective power of the lens, okay, and thereby allows for focusing at near, and this whole process is called as accommodation, correct? Focusing for near. So when you do this, it is an involuntary process. Okay, it is called as accommodation reflex. Why is it called as reflex? Because it is an involuntary process. You do not try to voluntarily focus on something near. Then if there is an involuntary process, there must be some stimulus, right? Because without a stimulus, a reflex is not initiated. For example, in the pupillary reflex, what is the stimulus? There is light that is falling onto the retina, and that initiates the reflex and ultimately results in constriction of pupil, right? That's pupillary reflex. So in this, there must be some initial stimulus, right? And the stimulus for accommodation is blur. Interesting, right? So whenever the eye perceives an object to be blurred, it sends signals to the brain, and the brain is not able to make a clear picture out of it. It tries to adjust the lens shape in order to focus it better. So this is the whole process of accommodation. But sometimes it is very important to know that sometimes this process is done too much. It is over exaggeratedly done and results in what? Because it's an involuntary process, remember, you can't really control the amount of accommodation, correct? So see this instead of making it 0, okay, I'll tell you, in hypermetropes, what happens? So in hypermetropes, the problem is that it is plus power. So whenever the person is trying to read for near, what happens is they try to see here, okay, already there is plus power, right? So when you are trying to see for near, you are actually increasing the curvature of the lens, right? While trying to do that, by mistake, or I would say by the power of the over accommodation, because the tone is very good in children, they make it so convex, okay, that it results in minus power. Instead of stopping at 0, so from plus, instead of stopping at 0, they go to minus power and still they experience blurring. So when the patients come to us and when we try to do subjective refraction by keeping lenses, actually paradoxically, instead of accepting plus power, they will accept minus power because it's so accommodated and stuck there. Okay, it is so stuck in this form that now it is difficult for them to relax it and come to 0, right? So being that the case, if you're not able to cycloplege or paralyze the ciliaris muscle, which is the main muscle which brings about this accommodation, you will not know the exact power at all. And by doing refraction erroneously, you will end up prescribing minus lenses to this patient or children. Okay, so what happens is constantly they will be accommodated and they will have minus power also. And remember, the longer you keep ciliaris in this position, the increased chances of headache. Because when we talk about so much eye strain, right? This is the eye strain. Keeping the ciliaris muscle contracted all the time by doing excessive near work is one of the main reasons for headache. Okay, and what is that called as? We've read it at the time of refraction chapter. Okay, so one second. Asthenopia. Remember, these are all asthenopic symptoms. Headache, watering, okay, blurring of vision. So this is why I wanted to bring up this topic of pseudomyopia. So they are not actually myopes, but they are hypermetros, but due to excessive accommodative spasm, while doing refraction, it appears as if they are myopic in nature. So definitely, whenever you see power of minus 0.5 or something, you must dilate and recheck the power after dilatation for dilated refraction. And to your surprise, many people will actually be hypermetropes rather than myopes. And you know all this concept, right? At the time of birth, we are hyperopic for a normal person also, okay, by about +3 diopters. As the eye grows, the person becomes orthophoric, okay, or emmetropic. Okay, then if the eye grows further faster than it should, then it results in myopia. Okay, so this is the actual trend. So in this early stages, when you diagnose myopia, you should be double careful to ensure that it is actually hyperopia or myopia rather than just blindly giving the prescribed power as we see in subjective refraction without dilatation. Okay, let's get back to this one. So this is the dosage of instillation, okay, ointment wise, and peak effect takes about, see this, 2 to 3 days. So when you do cycloplegic refraction, if you're going to give ointment, it's going to take much longer for it to bring about the cycloplegia, and hence ointment is more often given as treatment rather than for dilated refraction, right? So timing for performing retinoscopy is actually 4th day. So you have to ask the patient to come back to you after the 3 days and then do this. So duration of action is almost 21 days. That is 3 weeks. We say that your near vision may be blurred. This is the reason why we do not use atropine routinely for refractive purposes, because just to see 1 day of refraction, if you make the patient blurred for near for 3 weeks, the patients are not going to accept it, right? So post cycloplegic refraction, once I told you, right, this duration of action gets done, it is like pressing a reset button. Okay, so you're going to paralyze the ciliaris muscle completely and let it regain its function and then check it from start. Okay, so that is the 3 weeks of retinoscopy, the duration that you have to give. Okay, after 3 weeks only you should do the post cycloplegic refraction. So remember, this is the correction factor. Okay, what is this correction factor is, whenever you use this while doing retinoscopy, you need to correct for the amount of the tone. Okay, so what are you doing in cycloplegic refraction? You are going to reduce the tone which also contributes to some amount of power, right? Because the ciliaris is in a normal eye which is not dilated. What is the role? Ciliaris is going to be in a certain tone, just like our other muscles in the body. They are going to be in a tone, which is some amount of action at all points of time. Okay, they're not completely paralyzed. So in a cyclopleged patient, when we are doing refraction, you need to also account for that amount of power, right? And the amount of paralysis that is brought about by different cycloplegics is different because they are different in their own strengths, correct? So see this, atropine being the strongest, you have to correct almost one diopter because it's almost complete, paralysis. Whereas homotropin and cyclopentolate, they do not paralyze it completely. They just relax it to a greater extent than which is normal, and hence you have to correct it for only 0.5 and 0.75. Is that clear? So these are all predetermined values which you must take into consideration while calculating the exact power of the patient's refraction. Okay. So next drug is homotropin. Remember, homotropin is very commonly used in the children's age group, 5 to 8 years. So this is the duration or the frequency of dosage. So you almost do it for at least 3 times, if not 6 times, 1 drop every 10 minutes. And after 90 minutes of installation, you should do one. That is why it takes about 1.5 hours when you want to do a proper cycloplegic refraction for patients, right? And you ask them to come for PMT after 3 days because that is when the complete effect of the muscle relaxing effect of the phenylephrine takes over, and then finalize the power for PMT, which is nothing but post mydriatic test. Is that clear? So next is cyclopentolate, which is 1% drops. It can be used in slightly older children in their teens. Okay. Otherwise, the duration is pretty much the same. Okay. And lastly is the group of short acting mydriatics. Okay, in most of the adults and elderly people, we stick to this group because I told you, right, in children, the tone of ciliaris is very strong, so you need to completely paralyze it. As a person ages, this muscle, because of aging, the tone of this muscle will come down. Okay, and when it is come down to such an extent, that is, its strength is reduced to such an extent that it is not able to do even its normal function, that is what results in a condition called as presbyopia. Presbyopia is what? It is difficulty in seeing near vision because of decrease in the accommodative ability of the person. Is that clear? So accommodation becomes weaker with age, and hence you really do not need strong cycloplegics in order to relax this muscle or to be able to cause dilatation, right? So that is why tropicamide is one of the most common drugs which is used for refractive purposes. See this, it is not used as a cycloplegic, it is used only as a mydriatic. So 1 drop every 15 minutes for 3 to 4 times. Okay, after half an hour itself, you can do the retinoscopy. Okay, and also remember, this does not need a corrective factor because it is very, very minimal in strength. Now, in spite of this, if you do not want any cycloplegia at all, even theoretically also, if you feel, if there is still some contention that tropicamide also around 0.5 or 0.25 correction may be needed because it's still though a weak drug, it is still a cycloplegic because it is a muscarinic antagonist, right? So in such patients, if you do not want, like we saw in our patient today, okay, hypertensive patient who is 65-year-old, you can simply avoid phenylephrine, okay, because in them you can use only tropicamide because phenylephrine, though is only a mydriatic, it should not be used in hypertensive, like I told you, because it is absorbed through nasal mucosa. In such patients, tropicamide. But if it is 65-year-old who is hypertensive, who do not have these contraindications for phenylephrine, then you can use it as a simple mydriatic for dilated fundus examination. So I hope it is clear as to what is the role of each of these mydriatic or cycloplegic in routine refractive practice. Okay, so this very important point of different cycloplegics and their respective roles is very important for us to know before we proceed with everything. And one more point I wanted to touch upon here, atropine is very commonly used beyond refraction also. So I wanted to share a few non-refractive indications of atropine. Okay, so see this, atropine is used for control of myopia. But note the concentration, 0.001%. Okay, so it is used in controlling myopia. One more thing is, atropine is also used in penalization therapy. What do I mean by this? How does atropine help in control of myopia progression? Okay, myopia progression, that's the right way to put, because people are under the impression that you put some drops and you can get rid of glasses. That's not how it works. So what does this do? In myopia, the main problem is what? The eye is growing faster, right? Instead of being a sphere, it is more like an egg shaped. So the rays are getting focused in front of the retina instead of getting focused on the retina. So this is a simple problem in myopia. So what does atropine do? Atropine is going to bring about cycloplegia, right? So when it brings about cycloplegia, okay, so in 0.001 percentage, it is going to be very minimal. Okay, so it brings about a defocus. Okay, so it creates a concept called as defocus. Okay, and it is said to reduce the rate of this growth of the eyeball. Okay, why is the eyeball growing fast? Very simple, because in the near objects, when the eye is not able to see it clearly in the distance object, okay, because it's getting focused not the near distant object, okay, the brain sends signals for the eye to grow faster, right? So by using atropine penalization, atropine for myopia progression, what it does is it reduces this concept of growth of faster growth of eyeball, and thereby helps in control of myopia progression. Second concept in penalization therapy. How does it help in penalization? See, penalization therapy is used for a condition called as amblyopia. So students, note this term. This amblyopia can itself be a topic in discussion, meaning it is also called as lazy eye. So some questions can be asked from amblyopia also. Okay, so amblyopia is nothing but lazy eye. How does this happen? Okay, mainly because of stimulation deprivation, one of the types. Okay, stimulation deprivation or refractive amblyopia. There are many more causes. I'm just giving you the two most important ones. So long term, when the refractive error is not corrected, that results in refractive amblyopia. Whereas if there is some problem that does not allow the light to enter the eye, okay, in the form of congenital cataract, okay, or severe ptosis, okay, the eye under this pathology, like let's say ptosis or having cataract, it starts to decrease in its function. Okay, so amblyopia is functional visual loss. If you look at it, there is a decrease in the activity of the eye because of some issue in case of this stimulation deprivation. On the other hand, if there is refractive difference between the two eyes, okay, the eye which is highly affected by refractive error, let's say unilateral myopia, okay, because of a condition called as keratoconus. I'm sure you would have heard of this. So what happens is, here the cornea is very steep, okay, it is more conical, and the power in there can be even like -10, -11 diopters. Okay, the brain chooses to take more clear image from the other eye which is lesser affected or not affected, and this eye is not being used, and that results in amblyopia. So what are we doing in penalization therapy? So in penalization therapy, the better eye is made blur, okay, by using atropine ointment 1%. Okay, so when it is made blur, it stimulates the brain to use the weaker eye. So when the patient tries to see, he is forced to use the weak eye also to be able to see. This is very similar to patching. Okay, so patching, what we do, we use a physical way to, like a patch, to obstruct the better eye so that the person is forced to see through the weaker eye. So that can also be brought about by using penalization therapy, using atropine. So these are the two other non-refractive indications of atropine. Okay, so this is something that I wanted to highlight for the various cycloplegics and mydriatics that we commonly use in our ophthalmic practice. Okay, so I hope I have covered in detail about the mydriatics and cycloplegics. Okay, now before we proceed to the next topic, let's take a quick break.